Welcome, everyone. I'm Ellen Herman, co-director of the Wayne Moore Center for Law and Politics and professor of history at the University of Oregon. I'm so glad that each of you could join us today for a discussion of Black mental health matters. At this moment of racial reckoning in the United States, we believe it is critically important to shine a light on mental health in relation to the movement for Black lives and discuss the impact that policing and criminal justice have had and will continue to have on individual and community mental health. Today, we hope to explore how enduring associations between Blackness and criminality have intersected with Black mental health and illness, how the culture of mass incarceration has shaped the experiences of Black individuals with mental illness, and how Oregon's specific history of racism and exclusion and its tiny Black population have contributed to the mental health challenges facing Black people living in Oregon today. This event is part of the Wayne Moore Center's Public Affairs Speaker Series. We are so grateful to have had the partnership of the Eugene Springfield NAACP, the Lily Reynolds Parker Black Cultural Center, and the University of Oregon Division of Equity and Inclusion in publicizing today's event. For those of you not already familiar with the Wayne Moore Center, our mission is to advance the public interest by encouraging civic engagement and dialogue. We bring students, scholars, activists, policymakers, elected officials, and members of communities, people just like you, together. We discuss a wide range of issues affecting Oregon, our nation, and the world. We work in the tradition of Oregon Senator Wayne Morse, who believed that political independence and education were building blocks of justice and democracy. We have two very distinguished individuals with us today to speak and answer questions about why Black mental health matters: Martin Summers and Larissa Miller. I'm so happy to welcome them both. We will hear from each of them and then open the conversation up to questions from you. Please feel free to add your questions at any time to the Q&A button at the bottom of your screen. Martin Summers will speak first, so let me introduce him, and then I'll say a few words about Larissa Miller and then turn it over to our guests. Martin Summers is professor of history and African diaspora studies at Boston College, where he teaches courses on gender and sexuality in African American history, medicine and public health, and the African diaspora and the world. Some of you may remember that he was on the U of O faculty years ago, and we are always thrilled to welcome him back. Summers' most recent book, Madness in the City of Magnificent Intentions, A History of Race and Mental Illness in the Nation's Capital, is a social and cultural history focusing on the African-American patients at St. Elizabeth's Hospital, a federal mental institution in Washington, D.C. He traces their history from its founding in 1855 through to the 1980s. And he is currently working on a book about mental health policy and Black urban communities in the United States. Larissa Miller is a clinical psychology resident at Strong Integrated Behavioral Health here in Eugene, Oregon. She earned her PhD in clinical child psychology from the University of Denver, where her research focused on unconscious bias and nonverbal communication. Dr. Miller provides evidence-based psychotherapy to individuals from childhood through young adulthood and is currently recruiting participants for a free support group for BIPOC youth. BIPOC stands for Black, Indigenous, and People of Color. Martin Summers and Larissa Miller, we're so happy to have you, and I'm going to turn it over to you, Martin.
Okay, thank you, Ellen. And thank you all for attending, and I'm very pleased to be part of this important conversation. I want to thank Ellen for inviting me and Abby Steele and the rest of the Moore Center staff for organizing this. And also, I'm really looking forward to having this conversation with Larissa and the rest of you all. So I thought today what I would do is just provide a little bit of historical context for some of these important issues that Ellen raised in her introductory remarks, largely by talking a little bit about my book that I just recently published, and perhaps during the Q&A, I'll talk a little bit more about some of the research that I'm working on now. So as Ellen said, I've just published a book on St. Elizabeth's Hospital, which is a federal mental institution in Washington, D.C. And the book is basically a history of the relationship between that hospital and Washington, D.C.'s African-American community. St. Elizabeth's was actually founded in 1855 during kind of the first initial wave of asylum building in the United States. And its initial mandate was to treat, rehabilitate, house members of the U.S. Armed Forces, the U.S. Army, and the U.S. Navy, as well as civilian residents in Washington, D.C., who were too poor to afford a private care. And because Washington, D.C. had a very large African-American population, very early on, actually from its initial days, at St. Elizabeth's actually admitted African-American patients. Now, St. Elizabeth's was really considered one of the preeminent research and teaching hospitals in the United States from the mid-19th century to the mid-20th century. And it was also one of the few mental institutions in the United States prior to the 1950s to actually have a sizable African-American patient population. So it had a real a racially homogenous population, one of the few asylums in the United States to do so. And so the significant presence of Black patients at St. Elizabeth's really provided me an opportunity to examine how race and racism shaped psychiatric ideas and practices from the mid-19th century to the mid-20th century, or really to the late 20th century. So in addition to that particular line of inquiry, I also wanted to look at how African Americans engaged with the hospital and, by extension, the psychiatric profession, both as individual treatment seekers and as a community that would hold the hospital accountable for providing kind of equal treatment for Black patients. So in other words, I was really interested in how Black Washingtonians interacted with St. Elizabeth's in a way that allowed them to make claims or make demands on the state for equal treatment, make kind of citizenship demands on the state. So this first line of inquiry led to the argument, one of the main arguments of the book, that ideas about racial difference influenced how psychiatrists at St. Elizabeth's thought about insanity and mental health, and subsequently developed approaches to address them. So from the mid-19th century to the mid-20th century, psychiatrists believed that the Black psyche was fundamentally different from the white psyche. And this really contributed to a psychiatric consensus that Black mental illness was distinctive from a white mental illness. Mentally ill Black people were thought to be more depraved and dangerous than mentally ill white people, for instance. And so for example, in the second half of the 19th century, African Americans were diagnosed primarily as with mania as opposed to melancholia. So there was a preponderance of diagnosis of mania within the Black population as opposed to melancholia, which was the primary diagnosis of mentally ill whites. And this ended up shaping the therapeutic regime within the hospital. So it's really important, for instance, that one of the characteristics of the hospital was that patients were segregated on the basis of race. But racial segregation of the patients was not just a manifestation of racial segregation that existed in a larger society. Racial segregation of patients was actually justified by a therapeutic logic that held that exposure to the depravity and dangerousness of mentally ill Blacks would impede the recovery of mentally ill whites. Other ways in which the therapy was shaped by racist assumptions about an innate Black character was that Black patients, for instance, were much more likely to be subjected to mechanical restraints and isolation. Black female patients were much more likely to be subjected to hydrotherapy, which in the early to mid 20th century was a very kind of coercive therapy. And this reinforced the ideas that connected Blacks with kind of with criminality, right? Kind of African Americans were assumed to be kind of an inherently criminally prone. And I think another really important example of this is that between 1880s and the 1930s, African American male patients were housed in the same building and later the same complex with criminally insane patients and insane convicts, regardless of what the diagnoses of the Black male patient was or their civil status, right? They didn't have to be a convict to actually be housed alongside convicts. So again, that particular rationale for managing the patient population was based on this assumption that African Americans were an inherently criminal people. Another example of the ways that racist assumptions shaped therapy within St. Elizabeth's is that rather than using psychotherapy, here we're talking about by the early to mid 20th century, when psychotherapy became kind of a very important therapeutic approach to mental illness. Rather than using psychotherapy to get to the root cause of Black patients' mental disorders, psychiatrists used it to address the surface manifestation of their psychoses and to also remediate their condition to the point where they basically would just be well enough to perform labor, whether labor within the hospital or labor once they were released from the hospital. So even after you see the emergence of a post-World War II era consensus that race really played no role in an individual's psychical responses to external stimuli, and with the desegregation of mental hospitals across the nation by the 1950s and 1960s, ideas about racial difference still persisted within the psychiatric profession. And this is reflected, for instance, in the increasing disproportionate diagnosis of African Americans with schizophrenia once it became associated with violence and aggression in the 1960s and 1970s. So those are some of the examples of the ways in which ideas about racial difference really shaped how psychiatrists thought about mental illness. The second main argument that I make in the book is that Black Washingtonians, both patients and members of their social networks, their families and communities, really exhibited a great deal of agency when interacting with St. Elizabeth's. Okay, I'm seeing, and are you hearing me okay? Okay, great. And so this agency really manifests itself in both collective and more individualized forms. So for instance, we see individual agency in the ways that patients themselves sought to shape the conditions of their existence within the hospital by either challenging the medical authority of the hospital staff through everything from refusing to comply with orders to outright physical resistance. Families also interacted with the hospital by initiating the institutionalization of their loved ones, but also seeking to monitor the therapeutic experience of their family members once they were admitted. So in a sense, really families did not cede their own familial authority to the medical authority of the hospital staff or the state authority that was associated with St. Elizabeth's as being a government institution. And this is an important point because those proactive engagements with the hospital were occurring during a period when all Washingtonians, and particularly African Americans, did not enjoy full citizenship. I mean, when you think about it, Washington, D.C. itself did not have home rule until the early 1970s. So from shortly after the Civil War or Reconstruction to the early 1970s, Washingtonians could not elect their own city officials. They had no representation in Congress. They couldn't even vote for the president of the United States until 1961. So well, Washington, D.C. had, again, experienced a lack of citizenship, or Washingtonians experienced a lack of citizenship. And this is one of the ways in which, again, I argue African Americans attempted to exert their sense of citizenship by making demands on the hospital itself. And so this really reflected a rights consciousness, even though it was rarely explicitly articulated in rights language. And this rights consciousness also manifested in more collective forms of Black agency. So for instance, demands that were placed on government officials to conduct investigations of St. Elizabeth's in the wake of suspected murder of Black patients by attendants, by hospital attendants. In the 1950s, the NAACP and Black medical professionals in Washington, D.C. Pressed the federal government to desegregate St. Elizabeth's effectively, or successfully, I should say. Another example of this is public housing residents initiating a collaboration with St. Elizabeth's to establish a mental health clinic in their complex in the 1960s. And then finally, community residents' insistence that they have representation on the decision-making body that oversaw the transition of or part of St. Elizabeth's into a community mental health center in the 1970s. And I'll kind of end with this point. My focus on agency really is a corrective to a conventional wisdom about African Americans' apathy or hostility to psychiatry, which, you know, I started this project in 2001. I really began immersing myself in the scholarship on history of psychiatry and particularly race. There wasn't very much scholarship on race and psychiatry in the early 2000s. But one of the things that I think very much shaped my approach to the work was the ways in which kind of contemporary discourses around African Americans' relationship to psychiatry framed it as one of, as I said, kind of antipathy, hostility, indifference, and this is reflected in the 1999 report by the U.S. Surgeon General on mental health in America, in which some of the conclusions of that report is that African Americans, along with other people of color, really did not avail themselves of a psychiatry for a number of reasons. The belief that psychiatry is Eurocentric, and biased towards whites. And of course, my actual history of St. Elizabeth's illustrates that that's true to a certain extent. Another reason is that there's just been generally a historical mistrust of the medical profession, and also the tendency among African Americans to understand mental distress within a religious or spiritual framework and to seek pastoral care rather than professional professional psychiatric care. And so the conclusions of the US Surgeon General report was that all of these contributed to African Americans underutilizing outpatient services, which then resulted in them consequently being overrepresented in custodial institutions. And so one of the things that I tried to do with this book, and I continue to do with my research, is really to kind of problematize that by looking at the ways in which African Americans have historically engaged with the psychiatric profession, but they've always done it they've always sought to do it on their own terms. So I'll in there, and I'm looking forward to a conversation that flows from mine and Larissa's remarks.
Thank you so much, Martin. And this is a wonderful segue to Larissa Miller, who is herself, of course, a psychotherapist, and perhaps can speak to some of those issues about engagement directly with mental health services. Welcome, Larissa.
Hi, thank you so much for inviting me, Ellen, and everybody who put this together and made this possible. I really appreciate the opportunity to share this virtual space and time with you all. And I'm looking forward to this conversation, absolutely. So as Ellen mentioned, I am a therapist, currently a psychologist resident at Strong Integrated Behavioral Health. And part of the important work that we're doing is working in conjunction with Oregon Medical Group. So through the medical clinics, meeting people in a more familiar setting so that there's less stigma associated with seeking these mental health services, that they might be in a medical checkup visit and then they just briefly mention something that relates to mental illness or mental distress, coping with stress, behavioral things that might come up with kids or adolescents. And then that medical doctor can knock on my door, or one of my colleagues, and say, hey, I have a patient. Do you have 10, 15 minutes to talk with that person? And I found that really that integrated kind of mental health care can help people really familiarize themselves with what it looks like and what it feels like to talk with a therapist, and then whether having a more ongoing therapeutic relationship with a counselor might be fruitful for them or useful. So something that's really interesting and important to me, and that I investigated through some of my research at the University of Denver with Danny McIntosh and Tim Sweeney, is considering how individual differences can make such a big difference in how we perceive reality. That two people in the same situation might come away from that with two very different experiences. And I think that's something that we leverage through therapy and some of the interventions that we use, as well as just investigating how different people of different races and backgrounds can have really different realities as they're moving through life. So in my research, we looked at microexpressions, and those are unconscious ways that we're using facial expressions to communicate to one another, and in particular, emotional mimicry, facial mimicry of expressions, and that people tend to mimic other people that they feel they have more in common with, that they are more aligned with because of friendship, closer relationship, even similar race or major in college. Group memberships like that are really important and can lead to unconscious differences in how we relate to one another. And that at the end of that type of interaction, if somebody experiences a lot of those micro expressions that are being matched, they then go on to experience that other person as someone who is friendlier, that conversation was more positive, all of those things. And that's kind of going on in the background of our buzzing brains constantly, all the time. Another type of work that I became really interested in is the visual perception more on a more basic level, and how at any one moment our brain is just perceiving so many things. There's just this onslaught of data that we really have to narrow down so that we can be effective and efficient in interacting with our environment. And unfortunately, a lot of bias can get involved in that bottleneck process, where certain types of people or certain things are more or less visible or are more or less likely to come to our conscious awareness based on some of these biases in the background. And so things even as basic as just what we're noticing can be so subject to these biases, racism, different things that we're moving through the world experiencing. So as a therapist, I really keep this in the back of my mind that what we're working against and what we're pushing up against is this really deep-rooted history of racism and racist practices that is impacting people in these tiny, tiny little ways as we move throughout the world, and in ways that might be imperceptible, difficult to put your finger on, but it doesn't mean that they don't exist or that they're not happening. And it certainly doesn't mean that they're not things that we can't change. So on an individual level and working with people, I do a lot of helping people notice in what ways they can change the stressors that are occurring in their life, noticing the things that can be changed, that they do have power to change. So for example, improving parenting skills, communication skills effectively, things like that, self-advocacy in a safe and vulnerable way. And then also, in addition to working on those, changing those stressors, also improving coping skills more specifically for folks. So how can we improve and really broaden the list of tools and things that people have access to in their toolkit of coping skills, that when things happen, because stressors will happen, they can respond more effectively and really build up that psychological fortitude to be able to manage it.
Thank you very much, Larissa. We already have a couple of questions from our audience members, participants, both from on campus and off. But let me start by just asking you one question, perhaps beginning with the title of this conversation, Black Mental Health Matters, which was deliberately selected to point out the relationship between mental health and the Black Lives Matter movement that we're all witnessing and perhaps participating in, certainly reacting to now. So I'm wondering if both of you could perhaps comment from your different vantage points on the place that you think mental health holds, or you know, how mental health has been considered or not considered, or perhaps the impact that the movement itself and all of the kind of emotional, the buzzing in the back of our brains, as Larissa put it, is having on people witnessing and participating in this particular moment.
Do you want to respond? Okay. Well, I think I'll speak to this both from a historical and as well as just a personal. I want to make a personal observation about this. You know, I work at a university, and even though Boston College is a fairly conservative institution, both in terms of its policies as well as the profile of the average student here. You know, these past 5 years or so has seen quite a bit of student activism on campus, really beginning with the murder of Michael Brown in 2014, and continuing up through a number of incidents, both national as well as on campus itself. And one of the things that I think has been very interesting to me is to see the question of mental health addressed by student activists, right? I mean, one of the demands that they often make, or demands that they often make of the administration, is to provide the need for more mental health resources on campus to actually deal with racial trauma that they are experiencing, both through kind of microaggressions as well as kind of larger systemic racism. So I think that's really interesting. I think that it is kind of qualitatively different from the kind of activism that we've seen in earlier periods, earlier parts of, or earlier moments in the Black freedom struggle. Although, having said that, I also think that there has been mental health, as a civil right, right, or kind of the importance of, or the recognition that 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 mental health is really kind of bound up with the larger questions of civil rights and economic justice, has existed earlier in the 1960s and the 1970s. And you see that, for instance, with grassroots organizations, and this is connected to some of the work that I'm doing now, grassroots organizations in cities such as Chicago, Boston, Washington, D.C., really trying to collaborate with community mental health care advocates to address the questions of kind of mental alienation within communities, mental alienation that is caused by extreme poverty, kind of poor housing, educational discrimination, all of these things, racist policing. But one of the things I think was very is very clear is that in that collaboration, they very consciously rejected kind of a professional paternalism, right? They argued that if community mental health care advocates, if professional psychiatrists wanted to come into these communities to help, they needed to put the residents of these communities and advocates for these communities on kind of equal footing, on an equal level, that they themselves had stakes in their communities, and that they should be very vitally involved in any kind of decision-making processes. And they also really resisted kind of psychiatric objectification, right? They wanted to be clear that they weren't interested in being kind of the subjects of these study of these psychiatrists kind of coming in and looking and kind of trying to figure out the relationship between all the social ills that rack these communities and mental illness, but treating the residents of these communities essentially as subjects of observation, right? They wanted to be kind of, as I said, really vitally involved in any kind of decisions around what these kind of centers, these mental health clinics would look at, kind of what problems they would prioritize and whatnot.
Yeah, in terms of mental health, Black mental health, I really think of two kind of ends of the mental wellness spectrum. And I'm thinking about how people experiencing mental health crises often are met with police, met with law enforcement officers before they're met with mental health professionals. And I think a lot of organizations like locally in Eugene, Cahoots, trying to change that and really being a model for other organizations around the country, other law enforcement agencies, trying to figure out a way to get people the help that they need before just using that criminal model of how to manage mental illness, especially in a crisis situation. Then I also think about how currently with the kind of rejuvenation of the Black Lives Matter movement, Black folks, especially in Oregon with our 2 to 3% Black population, who have been most often battling microaggressions in their day-to-day life, whether that's in school, among friends, or in the workplace, now are having their white colleagues who often are well-meaning, but come to them and asking them questions about what they can be doing differently, what they can be doing better. Tell me about your experience, really focusing the spotlight on the Black folks to really be the educators. So while we are, witnessing the changes going on in the country and watching the news and feeling the stressors associated with that, also noticing more stressors just in the day-to-day, managing other people's emotional reactions too, and taking those on. So I think it is really crucial to keep in mind how Black mental health is so important to focus on as not separate from the Black lives that we're trying to save and protect, but really integral to that movement.
Thank you both. We already have several wonderful questions, so let me parlay them to you. One of them in particular comes from Michael Mushno, who is a member of our law school faculty and picks up on the comment that you just made, Larissa, about cahoots, which I think is being often sort of used as a national model of how a more therapeutic approach could substitute for, or certainly precede, kind of policing response, and is connected to the call for defunding or abolishing the police. But let me just use his question. With defunding and abolishing police and prisons gaining significant traction due to the movement for Black lives, an agenda for replacement gives considerable attention to therapeutic practices, for example, those used by cahoots and mental health strategies. Given that these practices and strategies have historically encoded racialized practices and punitiveness of the sort that Martin's research illustrates, what advice do each of you have for advocates who are encouraging these kinds of therapeutic and mental health practices to replace policing and prisons?
Yeah, great question. I think as well as giving more funding and attention to organizations like Cahoots that really do well in the crisis situation, getting people better connected to ongoing outpatient mental health care services, if that's what's needed. And oftentimes a big barrier, two joint barriers to that, I think, are stigma, and which is rooted in historic racism, malpractice, things like that, and the cost. And so I think by improving those things for folks, getting people in before it becomes a crisis, before it gets to that level, identifying people who might benefit from those services, I think can help to change kind of the pipeline so that we're not responding to as many crises and having to decide between a law enforcement approach versus a crisis management approach more therapeutically.
And can I also just say again, I feel more comfortable talking as a historian than providing any prescriptive advice. But I think it's really interesting, as Larissa just pointed out, this kind of bifurcation between a law enforcement approach and a crisis management approach. And I think it's really interesting to point out, if we kind of look at the community mental health care movement in the 1960s and the 1970s, which eventually, combined with kind of a patient's rights movement, led to kind of deinstitutionalization, right, in the 1970s and the 1980s. But one of the things about, one of the objectives of the community mental health movement was to decentralize mental health care delivery, right? So people would be treated closer to their homes, right, and kind of get rid of these massive, overcrowded state hospitals and kind of localized treatment in these community mental health centers, but also to provide I guess, non-psychiatric personnel with the kind of knowledge and skills, right, to kind of assist people who are having mental crises. And this not only included teachers and clergy, social workers, but also police. So this is in the 1970s. So that was considered to be kind of a progressive, right, a progressive idea. And then, of course, with deinstitutionalization, which was also an opportunity for the federal government, state governments to pass off the cost of providing mental health care to local communities, and then kind of the drawing up of resources. And we kind of know the story, right, with deinstitutionalization, increasing rates of homelessness. or the increasing incarceration of mentally ill people in the 1970s and the 1980s. And so, and that's created this, obviously, this kind of appalling reality now that prisons themselves are the largest mental health care providers in the country. And so, so there's kind of an unfortunate irony in that the progressive ideas, or some of the progressive ideas of the community mental health care movement, including bringing the police, law enforcement officers into, enlisting them into kind of this this effort to address and manage mental health crises, and unfortunately, now that it's really the police, law enforcement, and the penal system that is kind of completely taken it over, because there's just no funding for mental health care workers.
Okay, let me forward another question to both of you. Even this one comes from Elizabeth Wheeler. Even before COVID, there has been public discourse about an anxiety epidemic among US college students. And I would add that, there's been a proliferation of concern about the mental health of even younger children and students. What are good ways to bring race into the conversation about this? And perhaps Larissa, since this is your area of expertise, you might have a comment or two.
Sure, and I'm not an educator, but I think a helpful way to bring race into any conversation is just to destigmatize it and to bring it into many ordinary conversations. That for white families, talking about race should not be a taboo topic. In our schools, I think talking more about race in our history classes should not be a taboo topic. I think this really has to be from that educational standpoint forward, that then creates young people who feel comfortable understanding and conceptualizing their issues with anxiety within the context of a world that treats people of different races differently. So I think that's a big part of it. And I think anxieties in the current day and age, where we have video footage and instant connection to news from all over the world, it can be really difficult for people to shut that down and to just disconnect and really feel more connected with their present, in the present moment, what they're actually doing. So that's something that I do a lot in my work, is giving people permission and helping them to give themselves permission to disconnect for a little bit so that they can re-engage with their life, and balancing those two things.
Here's another sort of related question. Given the anti-Black history of psychiatry and psychology, what tips or insights might you offer to help Black students or other young people, or adults for that matter, to be better consumers of mental health resources? What questions should they be asking mental health professionals to assess their capacity to offer culturally relevant support? This question comes from Chris Esparza, and I might just add also something that came to my mind. What are the resources internal to Black communities? You have touched on clergy, educators, others, and what might be the particular role of Black mental health professionals in addressing these issues? Either one of you.
I guess I'll take this one first. Yeah, I think personally, as a Black mental health professional, there is a little bit of a different sense of trust that you can build just by walking into a room and seeing that your therapist is Black. Like, oh, okay, this person gets it on some level. This person understands a little bit of where I'm coming from. I'm not going to have to educate them to get them up to speed with what my lived experience is to a certain extent. And I think that that really is invaluable, and a reason that I'm really a large proponent of getting more people of color in the field in general. In terms of questions that somebody being a consumer of mental health services might ask their therapist, or when they're doing a Google search, I think is you can just ask your therapist how they consider issues of culture and race in the therapy that they provide, and then interrogate their answer and see how it sits with you. If they say, oh, it doesn't matter, I treat everybody the same, maybe that's somebody that you pass on and go to somebody who really fits you better. So I really believe that having a strong connection, and the research bears this out too, having a good therapeutic alliance with your therapist is very predictive of your success in therapy and therapy outcomes. So if you are not feeling it with a therapist, chances are it's not going to be as effective as kind of shopping around and getting with somebody who meshes with you better. And I think in terms of other resources that are available to folks in Black communities, just finding a community in general, finding your community, and then making connections with individuals within that feel good to you, finding good listeners. I think that's just so invaluable. So whether that looks like a yoga class for BIPOC identified folks, or flower arranging groups for Black folks, or whatever it is that brings you joy, finding a way that you can feel safe and surrounded by community, or if it's a church community as well, or another spiritual or religious organization. I think mental wellness comes in many forms, and mental health counseling is only one arm of that.
I would just kind of echo one of the first points that Larissa made, and that is the importance of having more people of color in the mental health care field, and then also having them, like for instance at Boston College, our University Counseling Center, I don't think has any Black staff, and so. I think that's important. Although I'm also not suggesting that one has to go to a therapist that shares your racial identity. But I think that it's critically important that we certainly have more people of color in the mental health care field. And I don't know what the numbers are now. I know that historically they've just been very low. I was just looking. And in the 1970s, I think something like less than 2% of psychiatrists identified as African Americans, less than 2%. And I think there's kind of a larger, there are larger historical reasons for the dearth of African Americans in the field of psychiatry. I'm happy to say that my niece, who is in medical school and getting ready to take her boards, is considering specializing in psychiatry. So I don't think she's read my book yet, though. So.
Yeah, I just wanted to add, I think that, so I'm not a psychiatrist, so I don't prescribe medication. I talk to people and listen. But I think that unfortunately, the proportion of psychologists who identify as people of color is similarly low, even in this day and age. And I think there are a number of reasons for that. Systemic educational differences in access to education, issues like that really contribute to the dearth of people of color at this level. But I absolutely think that that's an important place to start changing.
Okay, I hope we have time for one or maybe two more questions. There's a very interesting question from Mark Harris about, that takes us perhaps a little bit back to the past, Martin, for you, about how civil rights struggles have been considered or characterized as pathological or perhaps civil rights activism itself? And why wasn't racism itself considered a mental illness?
That Mark Harris from LCC. Hey, Mark. I can't see you, but it's good to see you. No, great questions. I think that yes, throughout history, people who have fought for civil rights, for Black people to be free, have often been characterized as mentally ill, as insane. This goes back to Nat Turner, 1831, or as we kind of think about the diagnosis that Samuel Cartwright, the physician from Louisiana in the early 1850s, claimed to have identified drapetomania, right? That is enslaved people who ran away were mentally ill because slavery was considered to be African Americans' natural condition, and to want to get outside of that was evidence of their insanity. And then we can kind of course, trace this up through the 1960s and 1970s, and the characterization of Black power advocates or Black militants as being, if not clinically mentally ill, certainly experiencing or manifesting the extreme kind of mental alienation. And the other question about racism as a mental illness, I mean, I think it has been, people have considered racism a mental illness. It hasn't ended up in the DSM as far as I know, but certainly Black physicians in the mid 20th century, people like M. Montague Cobb, who was a member, he's a Black physician and also a member of the NAACP, talked about racism. He referred to racism as the Confederate sickness. He talked about this having not being able to recognize the human in people who didn't look like you as a form of mental illness. And so I think that, certainly there have been people who have kind of argued or talked about or characterized racism as a form of mental illness, although I don't think it's ever been risen to the level of actually becoming a clinical definition.
Larissa, did you want to add anything to that, or shall I move along to a final question?
I guess I'll just add a quick comment on that racism comes in many forms, from microaggression to more broad, housing segregation and discrimination, things like that. So I think that saying that racism is a mental illness, which is something that's an individually assigned term, might be difficult to do. And I think we could end up with having to come up with a more strict definition of what racism looks like that might then invalidate the experiences of people who are experiencing racism in more quote unquote minor ways, or like those microaggressions that I was talking about. So that's an interesting point. I wonder how we might manage that in future editions of the DSM or diagnostic manual. So we'll see.
Okay, and one final question. Amazing how it flows from the comments that you've made. This one comes from Amina Cortos Serrano that I think addresses the sort of multiple manifestations of racism that you were just talking about, Larissa. Can you speak to how all of those different experiences, from microaggressions to bias to more formal forms of segregation or discrimination, impact not only the health outcomes of Black, Indigenous, and people of color, but the experiences of family members as well as the political climate more broadly? So not just the impact on individuals, but how these things sift out to the community at large.
Yeah, I think that's a big question with a lot of different components to it. That different experiences of racism kind of hit differently. I'm thinking about how that DSM that we were just mentioning, that manual has a class of diagnoses that are categorized as the trauma and stressor related disorders. And PTSD is one of them, post-traumatic stress disorder, as well as adjustment disorder, which is a maladaptive reaction to a stressor that occurs. And I think that generally people have specific reactions to stress, responses to stressors, whether it's a more everyday occurrence that builds up, like the death by 1,000 paper cuts kind of analogy, or a larger experience of trauma. And there are certainly manifestations of those reactions that are similar regardless of the diagnosis that we end up on, or whether that person is even assigned a diagnosis. And then in terms of how it can impact families, I think when you've experienced trauma, or when you are experiencing trauma more consistently, you really have like a tunnel vision of like survival. You're in survival mode. You're not thinking about how to thrive. You're not thinking about as much your goals, your hopes, dreams for the future. You're really like living day to day, surviving. And I think that really works against people's ability to be the best parents that they can be, the best siblings they can be, grandparents, aunts, uncles, all those different relationships kind of fall to the wayside when you're just thinking about making it through the day and getting the next paycheck, getting food on the table. So I think it really narrows people's scope of existence and the scope of their hope. And that's something that then I think goes on to impact community and how entire groups of people think about what's possible for the future and how to really sow the seeds for future generations and their success as well.
Okay, hard to believe our hour is up. I would like to thank both of you, Martin Summers and Larissa Miller, for the wonderful work that each of you is doing in your respective spheres, and for the insights that you have brought this afternoon to members of the Wayne Morse Center community. I hope that this very important conversation will continue, and I hope that we will be among the facilitators of that. Thanks to all of you out there for attending, and we look forward to seeing you at future events. On behalf of the Wayne Morse Center, goodbye. Bye. Thanks again.